I want to start with the insight that I had some years ago when I began to collect first-person narratives of madness. That is, narratives of madness written by people who had personal lived experience. And the bibliography that I think everybody's got a copy of, which is the 4th edition that I've compiled over the last, maybe I've been doing it for 10 years, something like that. This particular edition of the bibliography has 700 narratives on it, just a listing of them. Now, over the period of time when I first started to compile this bibliography, there were maybe 300 narratives on it in the first edition. And I compiled them because I constantly encountered people who would say, including all my colleagues in psychology and mental health, I constantly encountered people who would say, well, there couldn't possibly be a point of view about madness from the inside, since by definition, people who've been diagnosed with psychiatric disorders don't have insight into their experience. We know this is in every single standard textbook in psychiatry and psychology, in clinical psychology, that people don't have insight into their experience. So if they don't have insight, they couldn't possibly be saying anything about it. I mean, maybe they could write something, these people would say, maybe they could write something that would be completely chaotic and wild and crazy, but they couldn't write something insightful. And first of all, I didn't agree with that idea, but I couldn't seem to get across the notion that indeed there was a large literature that was made up of these first-person accounts. So I began compiling them, just so that I could partly say to people, listen, this isn't just a scattered 1 or 2 accounts here. This is a whole literature that we should be paying attention to. So once I got up to 300, I started compiling them in a bibliography and distributing them to people. Then I kept going. Now this 4th edition has 700 narratives. And let me note, these are, due to my own limitations in being able to construct this bibliography, these are only narratives in English. Of course, there are many other narratives in other languages. I'm just not able to compile them. And these are only narratives that have been published. And I did that on purpose, so that, of course, there are hundreds, countless other first-person narratives of madness that are not published. Either are in someone's drawer because they started it and didn't finish it, or because they didn't want to publish it, or because they couldn't get it published. The earliest of these narratives on this bibliography is from the 15th century, and the most recent is from whatever day I decided arbitrarily to stop compiling materials for the 4th edition. And whatever was published the next day will be in the 5th edition. So these are only narratives that have been published, and only ones that are in English. And once we got up to 700 in this edition, it became impossible for people to whom I would distribute these materials to say there isn't any first-person literature on madness. It's huge. And of course, these are only published narratives. There are, in addition, as I'm sure you know, many, many oral histories. There's a fabulous collection now housed, thank goodness, permanently in the British Library in London, called the Mental Health Testimony Project, which I write about in my book, which consists of 50 videotaped interviews by people who are quite courageous, who used their real names and allowed themselves to be videotaped with a tight headshot. They're completely recognizable. And who were patients in, now we'd call them Victorian asylums, most of which are closed now, but either had been long-stay patients or had been repeatedly admitted to institutions over a period of time. Most of the people in this project are now in their 60s and 70s and perhaps older, and they told the story of their lives. Each of those interviews is 4 to 6 hours long, and there are 50 of them. If you go to the British Library in London, you can watch these tapes. They're extraordinary. That's an entire other collection that's not a published narrative. There are oral histories, and now, these days, we can't even count the number of blogs and other kinds of materials that exist in which people tell the story of their own experience in their own way. And my challenge and my question, and what has led me to do this work, comes from the fact that even though this huge body of material exists, it isn't taken seriously, it isn't even acknowledged by most mainstream mental health practitioners. Now, I'm a psychology professor. I'm very interested in the mind and how it works. And so I have to ask the question, how can it be that people who consider themselves scientists and are interested in data and are interested in evidence and are interested in relevant material to the questions that they have to ask, how could they not be treating seriously a gigantic body of material like this? And I ask that just in a very straightforward way, and I challenge all of us to think about that question. How could that be? And so what I'm going to talk about today is trying to answer that question. So let's ask this question. Why is this huge body of material, first-person accounts of madness, why is this not treated seriously? Why is it not even acknowledged as existing, despite my bibliography? Now, first we have to realize, even though this seems hard to me to realize, that most mental health professionals do not know that this body of material exists. They might have heard of a best-selling book, and depending on what generation they come from, that book would be, for somebody today, it might be Girl Interrupted. From somebody in a slightly previous generation, it might be I Never Promised You a Rose Garden, or The Snake Pit. These are all books that became widely read outside of the mental health community. And so people might have heard of those books, and they might have thought, yeah, there were a few crazy people who wrote about their experiences, yeah, I guess. But that doesn't mean I should change my ideas about mental health. So one would say. Let me just make one thing clear before I go on. When I talk about mental health professionals, I will often say they. And that's because I don't include myself in this population of people. And let me make very clear where I myself am situated. I'm a psychology professor. I am a psychologist. I have a PhD in psychology. I'm a psychology professor. I am not a clinician of any kind. And as I have often said, when I have gone to meet with a group of people who were quite suspicious of people from the mental health system for perfectly good reasons, given their own experiences, I've often said to people, I've never seen anyone in treatment. I've never given anyone a medication. I've never sent anyone to hospital. I have nothing to do with that system. I'm a professor. I'm interested in how the mind works, and I'm interested in what I can learn from a great variety of different kinds of people. And so it's been very important in my work that I've been able to clearly say, I'm just not part of this system. I have a lot of friends and allies and colleagues who are in this system, but I'm not part of it. I'm not a patient. I'm not a therapist. I'm not part of a system that has a set of assumptions. So I can stand outside of it and look at it. Okay. So if we ask ourselves, why is it that mental health professionals don't treat first-hand accounts seriously? Let's start with this key quote. Probably all of you have heard the name Emil Crepin. Emil Crepin is probably the most famous figure in the history of psychiatry. He was a German psychiatrist in the 19th century, and his ideas about how to classify mental illnesses, which is of course what he called them, still continue to inform our ideas today. If you know about the structure of the DSM, the Diagnostic and Statistical Manual published by the American Psychiatric Association, or any other classification system of mental illness, what's quite striking is that it's barely changed. I mean, the terms might have changed, but the basic ideas are barely changed from what Crepin did in the 19th century. So it's appropriate to start with Crepin. And let me read a statement that Crepin published in 1919. I'm going to quote from him here now. The faculty of judgment in the, he called them Dementia praecox, that's the old name for what we now call schizophrenia. The faculty of judgment in the dementia praecox patient suffers without exception severe injury. What always surprises the observer anew is the quiet complacency with which the most nonsensical ideas can be uttered by them, and the most incomprehensible actions carried out. One has the impression that these patients are not in a position to accomplish that mental grouping of ideas which is a requisite for their survey and comparison, their subordination among one another, and for the discovery of contradictions. In other words, what Crepin is saying is, by definition, a person who has a diagnosis of psychosis is saying things that are nonsensical. That's a core part of who they are and how their minds work. And so, essentially, by implication, we can understand Crepin saying, why would we want to read anything such people wrote? By definition, it doesn't make any sense. They can't accomplish, as he called it, the mental grouping of ideas, which is a requisite for their survey and comparison. They can't say anything that means anything. Now, before we get to some of the implications of this core idea, which I think is very much behind why first-hand accounts of madness are not treated seriously, let's think a little bit about psychiatry as a field and its history, because it's very, very relevant to our understanding of what it's like today. First of all, psychiatry has a very odd history, more odd even than you might appreciate. And let me note a few features of its odd history. First of all, it's the only field of medicine that has always had an active vocal opposition. In fact, we know the word. If you're a social scientist, you know this word. If you're in the mental health system, you know this word, antipsychiatry, right? Now, imagine how ridiculous it would sound to talk about anti-cardiology, anti-pediatrics, anti-endocrinology. We don't have words like that, because in those fields, there isn't an active body of people, and there hasn't been throughout the history of these fields, opposing the core ideas of the field. And anti-psychiatry has always referred both to people within the field, that is psychiatrists themselves, who are critical of the field, and people from outside of it, especially people who have been patients, who have been critical. So first of all, psychiatry is a field that has always had people criticizing it, enough so that there's an entire name for the body of people who are critics. Second of all, another very peculiar feature of psychiatry is this, and this comes to what I'm focusing on. You know, most of the history of psychiatry has involved institutions where people were sent for long periods of time. A few of those are unfortunately coming back today, but mostly we don't have those so much today. But in the history of psychiatry over the last 200 years, that's what we've mostly had, is long-stay institutions. And most of these institutions, as I'm sure you know, were built in places out in the country on a theory that partly makes sense, that it would help people to have fresh air and work on a farm and so on. But in any case, these places were isolated, usually, these institutions. And it used to be, until the middle of the 20th century, that the staff who worked in those places, psychiatrists, nurses, psychologists, would also live on the grounds of these institutions. And so what you had was a very unusual population, staff and patients living together in places that most of the rest of the population would never even visit. They were usually far away, they were behind locked gates, and they were in this strange environment. And what people haven't appreciated, and what I've really focused on in my work, is how in this world that few other people could really imagine, the world of the asylum, both doctors and patients wrote about their experiences. Patients, and I'm going to, at different times in this talk, refer to people who've been sort of on the service end of the mental health system in different ways. I'm not going to use, when we're talking about the 19th century, a word like service users, which has a more political meaning and is a more contemporary word. I'm going to use a word like patients, but of course I'm problematizing these words. But in the 18th century, in the 19th century, in the 20th century, what psychiatrists did not realize is that just as they were sitting in their offices in these asylums writing about the people who were on their wards, the patients, often in secret, were writing about their own experiences. And they were doing that even if they had to do it under extraordinarily difficult conditions, even if they had to hide all of their work, even if they had no paper, even if they had to write in blood, even if they had to scream because they didn't have any other means of recording their experiences. That's what's so extraordinary, is that people who have had lived experience of emotional distress have tried in every conceivable way for hundreds of years to provide accounts of their experiences. And so psychiatry is a very unusual field in the respect that it's always had criticism from inside and outside, and it's always had a sizable body of people who are its patients writing their own accounts that stand in opposition to the accounts of psychiatrists. And this is what is so striking, because in a field like psychiatry, where there is no agreed upon body of knowledge, where there are questions always being raised, where the biological bases of mental illness, for example, which have been hypothesized for 200 years and have yet to be found, where there's a lot of question about what is it that the professionals in the field are saying, alongside there has always been another way of understanding those phenomena created by people who have had their own experiences of them. Now, what's an interesting comparison is that patients in other areas of medicine, like someone who has heart disease or cancer or AIDS, might write an account of their experiences. We all know about books that have been written by people, say, who've had cancer, about what it's like to have cancer. Books like that certainly tell people's story of suffering and what they've been through and how they've handled their difficulties. But people who write accounts of their cancer experiences or their heart disease don't think that they're contributing to the field of medicine relevant to their difficulties. So a cancer patient doesn't think, I'm writing an account of my experience as a contribution to oncology. Because patients who have cancer agree with their doctors that there's a body of knowledge in oncology that both patients and doctors agree to about how cancer operates in the body. That's oncology. Writing an account of your cancer experiences might be very, very important and might be very useful to you and other cancer patients, but it's not part of the scientific literature in oncology. Everybody understand how I'm saying this? Same for heart disease, endocrinology. Psychiatry, it's not the same thing. We don't have any clearly agreed upon scientific knowledge in psychiatry. We have a lot of theories, we have a lot of hypotheses, we have a lot of research findings. But the key point that I'm trying to make is that some of those materials have been created by professionals, and some of them have been created by patients. And since there isn't any consensus in psychiatry about what's known and what's not, accounts by people who have been patients are a lot more threatening to the status quo. You see what I'm saying? In a way that an account by a cancer patient is not threatening to knowledge in oncology. A lot of people who have been mental patients write accounts of their experiences because they don't agree with the treatment they've been given, because they have a different account of what their problem is, because they have a different way of understanding what would help them to cope with these difficulties. In other words, they're essentially presenting an alternative model of madness, an alternative model of treatment to that of their doctors. And psychiatrists have understood this. They have understood, in other words, that accounts, first-person accounts, are very threatening to the status quo in psychiatry, because there isn't such a clear body of knowledge for psychiatrists to rest on in the same way that doctors in other fields can do so.